Hello everyone, I am Dr. Bipul. I am an ophthalmic surgeon working in KG Hospital, Coimbatore, Tamil Nadu, India. So today I'll be discussing something on glaucomatocyclitic crisis. This is also known as Poshner-Schlossman syndrome. Poshner and Schlossman described this in nine patients in the year 1948, which is characterized by recurrent attacks of unilateral acute secondary glaucoma associated with mild uveitis, and there is significantly raised intraocular pressure. This affects typically young adults, males. So affected patients tend to be younger in the age group of say 20 to 50 years with a male predilection. So these attacks are episodic, unilateral, with a marked elevated IOP of 40 to 60 millimeters of mercury associated with mild anterior uveitis, and there will be anterior chamber reaction which is very mild, and there will be small to medium size non-granulomatous uh, KPs on the endothelium. Posterior synechia and peripheral anterior synechia are generally absent, and the drainage angle is open. Each attacks generally lasts for a few hours to a month, but usually this lasts between 1 to 3 weeks, and the recurrences are always on the same eye. Antiglaucoma treatment does not abbreviate the attack, and iridectomy or filtering surgery do not prevent recurrences. And in between the attacks, generally the signs and symptoms are not there, and the contralateral eye remains normal. During the attack, there is unilateral mild discomfort, halos around light, and slight blurring of vision. Now, what is the etiology? In the modern literature, there is evidence which has emerged in the support of various infectious agents, uh, including CMV, Helicobacter pylori, varicella zoster virus, herpes simplex virus, and Borrelia burgdorferi. The PCR of the aqueous has been used to confirm the presence of CMV, and the lack of PCR positivity during the times of quiescence, and a positive Goldman-Whitmer coefficient which compares the levels of intraocular immunoglobulin that is in aqueous as compared to that of the serum, which is measured by ELISA, as well as therapeutic response to anti-infective agents or antiviral agents, suggest the causal relationship with evidence supporting CMV as the etiologic agent. Now, this syndrome has also been described in association with peptic ulcer, and uh, genetic marker has been found in most of the cases like HLA BW54. And ELISA of serum of patients with this syndrome has been tested positive for H. pylori in 80% of the cases as compared to controls, which is 67%. Now, what is the pathophysiology? There is trabeculitis leading to blockage of the trabecular meshwork with mononuclear cells, and this leads to rise in intraocular pressure, and sometimes there will be uh, alteration in the optic nerve head blood flow, which can be seen on transient ERG with S-cone response reduction, and with frequent attacks there will be mild loss of endothelial cell density, which can be found out by specular microscopy. Now, coming to differential diagnosis, this syndrome should be differentiated from primary open angle glaucoma. Here, both the eyes are involved. There will be no uveitic signs and symptoms which can be seen. Inflammatory open angle glaucoma, where you will find posterior synechia and peripheral anterior synechia. Pigmentary glaucoma, where you will find pigmentation which is there in the endothelium as well as in the trabecular meshwork and anterior capsule of the lens. Then pigmentary glaucoma, it generally occurs when you do too much of exercise, or there is dilatation of the eye. Then neovascular glaucoma, it should be compared with uh, in neovascular glaucoma, you may find neovascular tufts around the pupillary margin or in the iris or in the anterior chamber angles. Then Fuchs heterochromic iridocyclitis, it should be differentiated from this, uh, where you will find heterochromia of the iris. Now, what are the investigations you will do? Anterior chamber paracentesis has to be done to reveal the infectious etiology, and a PCR has to be done from the aqueous which is collected, and a treatment is directed against the agent rather than just treating the intraocular pressure. Gonioscopy has to be done to see for posterior synechiae and peripheral anterior synechiae, and whether the angles are open or closed. Visual fields has to be done to find out the glaucomatous changes which can be seen in these cases. Advanced glaucomatous changes can be seen in these cases, as well as mild changes with visual field loss. So coming to the management, how will you manage? It can be managed by hypotensive measures, anti-glaucoma medications like topical apraclonidine eye drops of 0.5% or brimonidine eye drops of 0.1 or 0.2% twice a day or 3 times a day, particularly during the attacks, with supplementation with uh, aqueous suppressants like beta blockers, timolol, or carbonic anhydrase inhibitors, brinzolamide or dorzolamide. The role of prostaglandin derivatives is yet to be established, because prostaglandins generally cause inflammation, and generally it should be avoided in these cases. Rarely, hyperosmotic agents like mannitol of 20%, 1 to 2 milligram per kg body weight, should be given over 45 minutes, where the IOP is more than 50. Anti-inflammatory measures, some of the clinicians they consider using it, but there is no evidence which has been found that it shortens the attacks or prevents the recurrences. Topical steroids like predacetates of 1% 4 times a day, or topical NSAIDs like ketorolac 0.5% 4 times a day for a week or so may be useful. Cycloplegics are generally not required. And should the aqueous comes as positive for CMV, then treatment of CMV with ganciclovir topical ointment and systemic valganciclovir should be done. Topical ganciclovir of 0.15% every 3 hours, in addition to oral valganciclovir of 900 mg twice a day or 450 mg twice a day according to the creatinine level for 21 days can be of benefit. And systemic treatment is generally required in all cases of CMV. And because valganciclovir is not benign, and it causes serious toxicity, where you will have anemia as well as decreased white blood cell count also. So it should be monitored and accordingly given. Now, follow-up of these patients. This patient should be seen every few days for the first week, followed by weekly follow-up until the episode resolves. If the IOP decreases to normal level and is not associated with any disc damage, no further treatment may be required. Both the eyes are at risk of developing chronic open angle glaucoma, and this patient should be followed up, say, every 3 to 6 months intervals for IOP checkup and optic nerve head changes. The visual fields, fundus photo, and OCT measurements should be repeated annually to see for glaucomatous changes, and accordingly it should be treated. Thank you.